If you watched the video that I made a couple of weeks ago from Flightbridge's FAST conference, you saw me talk about eclampsia and you heard me talk about waiting up to 5 minutes for a seizure related to eclampsia to stop. There's a lot of people that really struggled with that, and so I wanted to bring an expert directly to speak to this, and I'm speaking to Liz Garcher, right?
Correct, yeah.
And what are your credentials?
Yeah, so I'm a double board certified OBGYN maternal fetal medicine physician.
And how closely do you work with, well, you obviously work closely with emergency providers there. How about people like in emergency rooms? How much interface do you have with that?
I would say a moderate amount. I work at three different hospitals, UNM being one of them. And so I would say, like probably twice a week, I go down to the ER at one of the other two places. I also work Presbyterian and Loveless.
Okay. And when you speak to this, like to eclampsia and other OBGYN related issues, I'm assuming that this is not just to inform people who work in OB, but this is also to inform people who work in the emergency environment.
Definitely. I feel like that's a huge thing that we've had to and importantly, put an emphasis on because this is something that happens in such a pre-hospital setting frequently, right? Ideally in the hospital, but definitely can be outside of that situation. And also in New Mexico and nationwide, we're having OB/GYN shortages. And so it's important for OB topics to be covered in emergency room settings and pre-hospital settings in order to bridge that gap as much as possible.
So I'm an emergency provider out in the field. I get a patient. It's a woman who is pregnant. She's, we'll say, 5, 6 months along, and it's reported to us that she suffers from preeclampsia. What is the difference between preeclampsia and eclampsia?
Yeah, eclampsia is the manifestations of actual convulsions, and preeclampsia is hypertension, and there's a bajillion other criteria that kind of go along with that. And they don't necessarily come as a continuum. They don't always go from preeclampsia to eclampsia. You can absolutely have your presenting symptom be a seizure.
Okay. And what is the threshold, the blood pressure threshold that we are concerned about when it comes to eclampsia?
Yeah, so I would say that in general, preeclampsia is diagnosed when you have a blood pressure of 140 systolic or 90 diastolic. And so that's when I would be concerned about a pregnant woman with elevated blood pressures in general for preeclampsia or eclampsia. And then eclampsia doesn't necessarily even have to have blood pressure elevations. It's really all about the convulsions as the diagnostic criteria.
Okay, so I'm an emergency provider in the field. My patient is with child and she is hypertensive. She has a blood pressure of 150 over 100. What are my priorities?
Yeah. So in that situation, I would definitely be discussing obviously the history and physical with the patient, but we want to make sure that we treat that blood pressure as quickly and safely as possible. And that can be done a few different ways. The most common medications that we use for decreasing that blood pressure with a goal of being less than 140 over 90, depending how high we're starting. Obviously, if you're starting at 200 over two 200 over like 180 or something, you're going to not want to drop it to 120 over 60 rapidly, but you're trying to get lower, definitely decreasing by 20% or so if you're at that higher end. And so the medications, as I got off a topic there, that we most commonly use are either labetalol or nifedipine. And labetalol would be something that I'd think about if someone has asthma, because that can be, as a beta blocker, right, associated with asthma exacerbations. But in the acute setting, something that we could still think about IV, we do it PO in the outpatient setting, but obviously that ain't going to cut it in a pre-hospital setting where we're worried. The other is nifedipine, and nifedipine can be either immediate or extended release. And so the advantages of that are that it's an oral medication, so you don't have to have an IV at all, but it does precipitously drop blood pressure, right? So that is something that can really tank somebody if you go big on that. So I usually start with 10 of immediate release in that setting.
That's the critical care environment and where you're likely to have maybe all of those medications.
Totally.
Let's say you're in a 911 environment and you really have nothing that specifically targets blood pressure. Your priorities then would be what? Rapid transport?
Definitely. Yeah, yeah, because is associated with, especially the elevated blood pressures, with that escalation to eclampsia, possibly.
Oh,
So it is important to have rapid transport to get to that treatment, the goal being under 30 minutes if possible.
okay. What about mag for prophylaxis in that environment?
Yeah, that's a great question. So that's something that's pretty hotly debated in the MFM world, if that's appropriate. So actually, if you look at some of the early studies, the um, group that had the highest rate of seizures were those who had not like preeclampsia with severe features, which we consider worse, but those without severe features. So there's some argument that maybe everyone should just get MAG prophylactically if you have that diagnosis of preeclampsia. But for sure, absolutely, there's good evidence that in eclampsia, MAG is the thing, right? That is the thing that helps the most. That's the thing that's going to prevent future seizures. That's what's going to help keep mom from stroking out. So in eclampsia, when you have a pregnant woman seizing, I say a pregnant woman seizing is eclampsia until proven otherwise. And so I think that it's important to treat with MAG being a big priority in that setting.
In that instance, it's kind of problematic for EMS in that
Right.
we associate almost all seizures with some sort of epilepsy or other sort of seizure disorder, and that's not actually what's happening. This isn't a seizure disorder or an epileptic disorder, right?
Exactly. No, this is a manifestation of that irritation of the brain itself. And so we think, although not 100% sure, that that magnesium sulfate is going to increase your seizure threshold, so making it harder to seize, and that being the main way that it improves the chances of not a recurrent seizure. So it's not treating your current seizure, which should resolve on its own. It's actually instead helping prevent the next one.
Okay, and that brings us to the subject that everyone was a little bit nervous about was the fact that you say it should resolve on its own. And one of the numbers that that threshold reached in that discussion was even maybe up to 5 minutes. And
Right.
there was some people who were very, very strongly in support of that a benzo should be applied way sooner in that regard, and that at the 5 minute mark you should actually be thinking about like propofol and a paralytic. So, what is your response to that?
Yeah, no, and I totally get that because it's true. Generally, seizures, especially in like young, healthy people otherwise, are more related to other things, right? Substance use or a seizure disorder. And so it's not appropriate to be waiting for someone in status. And that makes sense, absolutely. But in a pregnant woman who doesn't have a known seizure disorder, the most likely diagnosis is this eclampsia. And the thought behind why we don't recommend a benzodiazepine sooner essentially is because we want to be able to have a really good neuro exam when that patient stops seizing. But I would say, hey, if we're out in the field, we got an hour transport, we don't have, even probably enough mag to be doing a full mag dose or something like that. It's not inappropriate to be like, oh, I'm not really sure, I don't have corroboration that this is not a seizure disorder, and treat at that point. I would say that I would definitely be like, I get it, that makes perfect sense. But waiting is appropriate as far as what we say in the guidelines. But again, this is set up for a hospital setting where, yeah, if you decide at 6 minutes, you're like, well, she didn't stop, we better get that propofol, we have it right here. That's different, right? So it's,
Yeah.
as with many things in the pre-hospital setting, I would say I wouldn't fault anybody who gave a benzo at like 2 minutes because they couldn't watch it anymore and were concerned about this patient.
So really, it comes down for maybe the EMS provider. Is this seizure related to eclampsia? Which you say most of the time, the overwhelming majority of the time, it is going to be. But
Correct.
I'm not sure. There's no declared history of preeclampsia. And then also the consideration of how much mag do I have. The average, at the crosscut of all EMS, they may only carry 4 grams of mag. So what would be our loading dose of mag?
Yeah, so the goal would be depending how you're administering it. So if you have an IV, you'd want to load a 6 gram bolus, although some literature does say 4. So if you have 4 and you load that IV, that's an appropriate treatment dose. And then if you have an IM, then you're doing 10, so 5 in each buttock. Grams of mag, so quite a bit, which, like we say, probably don't have even that much.
Okay, and over how much time would you want to give that if it was IV?
If it was IV, it's like I think a 10-15 minute bolus. Like it's something that you want to run rapidly, but not push wide open, essentially.
Okay, and is there any maintenance that you're going to apply after that?
Yeah, so ideally you'd have a 6 gram loading dose and a 2 gram an hour maintenance dose. But mag is not benign either. Like having high doses of mag in that setting can lead to essentially respiratory depression and cardiopulmonary collapse due to that. So it's definitely something to be monitoring, especially in these preeclamptic patients. They often are having elevations in their creatinine or other differences in their ability to be able to, well, really it's the creatinine, right? So they're not then urinating and they're going to not be able to excrete magnesium. And so it's also important to be watching that. So if you have a patient that has oliguria, and you already gave that 4 gram loading dose, maybe holding the mag until you get there and can get a mag level.
Okay. And let's say that we do have to resort to giving benzos. Is there a preferred benzo?
Yeah, no, not really. And the literature is not super strict on that for sure.
Okay, great. Well, I think that brings clarity on the situation, and I want to reiterate that what you're saying is that the EMS provider should maybe have a little bit of a lower threshold for benzos if they really, it's kind of undifferentiated seizures to them, or if they really don't have the dose of magnesium that they should have, and also really just responding to their own index of suspicion and their level of concern. They shouldn't be too afraid to give the benzo. The benzo itself is not going to be harmful, correct?
Exactly. Yeah, definitely. I think that it's important to remember pre-hospital special, right? It's definitely a totally different world. And that if it's not that that's going to harm the baby or the patient in that situation.
And why wouldn't we be concerned about fetal hypoxia, say, starting into the 2, 3, 4 minute mark?
Yeah, no, definitely. We would. That is something else, but we know that treating eclampsia essentially, or even waiting that time, we tell people in the hospital setting just take off the monitors. Like it's going to look terrible because that baby is hypoxic, but it should recover well as mom stops seizing, and prevention of the next seizure is much more important in that setting.
Okay. And in these patients, we're not likely to see the type of postictal period that we would in kind of your other type of seizures, right?
Exactly. There shouldn't be that huge postictal period. They should come back pretty clearly, pretty rapidly as well. And that's the other thing that some people talk about with use of benzos early is that you wouldn't necessarily be able to tell a future seizure kind of a thing because of being snowed in that situation. But again, I think it's all relative and it's very clinically specific depending on your situation.
Okay. And let's say you've given mag and
Mhm.
your patient actually still has another seizure. So now you've resorted to using a benzo, and you actually are in a state of status uh,
Mhm.
for all intents and purposes. Can you still go down the same tree as far as all the backup anti-epileptics, or is there a different protocol?
No, definitely the same at that point.
Okay, even ketamine.
Even ketamine. I would
Okay,
say my number one thing is death 100% crosses the placenta. So anything to help mom get her out of that status is going to save baby and mom. So it's important to use what you have.
excellent, Dr. Garcher. I really appreciate you bringing clarity to this with us.
Yeah, thank you.